Oh, the manic patient. So these are the ones that you kind of, classic ones, somebody's, preaching things in the middle of the street and they, wearing these extravagant clothing, lots of rings and, it looks very odd and multicolored hair. Multicolored hair? Good, no, normal people in here today. Great. So, these people are bipolar and, they've kind of swung from one to the other and usually it's because they're not taking their medicines, there's some kind of drug or alcohol abuse or family issues. They've kind of come into this arena, so to speak. And so, but most bipolar people can lead very normal lives most of the time. And occasionally they don't, so it's kind of weird. We get our population is probably a little bit more lower income, I would say, but occasionally you get some manic person who, has an iPhone 6 and big one and has a whatever Michael Kors purse and has all this kind of stuff. I don't know why I'm using a woman on this situation, but an Armani suit, a nurse. Is pretty well dressed, but they just kind of look a little weathered and they haven't been showering or changing clothes and taking care of themselves, and so just kind of gone off their rocker just a little bit, so to speak. So you kind of treat them the same way as you would an agitated patient. Kind of reorient them, and try and because they feel great, right? They feel awesome. They're going to take over the world. They've got this plan for this next greatest, business plan, and they just need to get to Albuquerque so they can meet this guy and buy this thing, and so they've got this. You got to kind of calm them down and try and get them back oriented and get them some help. So anxiety, sometimes over kind of comes in the ER a little bit too much, probably for some of this stuff. The people come in and say they're having a panic attack and they're sitting there playing on their phones and, I don't know, I believe you. So, but somebody can actually have a panic attack, you get this agoraphobia or whatever, just sitting in a classroom can do it. So, and so these people actually get some physical symptoms from it. So, you get actual tachycardia, and they're sweating, and they feel chest pain, and they're shaky. So these people actually might actually benefit from some medicine, or just kind of calming down and reassurance that they're doing okay. So, sometimes just kind of, basically ruling out that their chest pain isn't a heart attack. It was just enough that they need to kind of calm down. So some of these meds, we try not to use a whole lot of benzos for something like this, but every once in a while, a little shot of Smatiman or something like that's probably okay. We definitely don't do a whole lot of prescriptions for benzos in the emergency room. Too abused out there. Gotta get your Zanny bars out there. So bars, blue footballs, pink footballs. So got no street lingo. Okay. So and Atarax. So we do a lot of this. Some people that have some gaps and when they're going to be able to get in to see a doctor or something like that, they're very anxious, those kind of things. They're not sleeping well. Sometimes some hydroxyzine or Atarax is beneficial for this. You can kind of help them rest, calm them down a little bit. So it's basically something that tastes like super Benadryl. Works well for aging too. So can I recover this a little bit? So. Don't use the paper bags therapy, have them breathe into a paper sack. It's not good. Sometimes they'll want to put people on like this, rebreather mask where they have this bag on there, kind of like the airline one that drops down. So you don't want to do that because you're just breathing back in CO2. What's going to happen if you continually breathe in CO2? So then you got another problem on your hands. More work, more documentation. So. Still got to rule out the medically stuff to make sure they're stable. Okay? Questions on that? Drugs and alcohol. Obviously, we see a lot of drugs and alcohol. You would think, well, why is somebody coming to the emergency room for, seeking treatment? They don't have any other option. They don't have a doctor to go to. They've got, maybe a free clinic or something like that, and they can have some resources and things. Or my ER is listed in their and their packet of stuff they got from their church or community group to come help them. And so, well, like St. Anthony's has a medical detox facility, and so what this is not rehab, it's for certain drugs, getting you off safely down from one level to another level so that you can manage it without going to severe withdrawal symptoms and kind of spiraling out of control or getting really, really sick. So, and so, you know, it's pretty hard to get into these programs, to be honest with you. You have to have, you know, usually insurance, whether that's, you know, Medicaid, Medicare, or private insurance, something like that. Like for ours, if somebody wants to self-pay for this program, it's like $5,600. So, not cheap. So, you need to have a benefactor or something like that that's going to help you with this. There are other programs in the city, TRC, through the Salvation Army, and stuff have programs. But you know, a lot of people come in here expecting that we can do something for them, so that's kind of a hard, you have to kind of help manage expectations, of course. So, and so, you know, they're wanting some relief from withdrawal symptoms, so there's a few that are really, really bad, there's a few that just kind of suck. And so, you don't have to do a medical detox for all of these things. And some levels of things you don't really need to be worried about as much. But so sometimes these people will become suicidal or hopeless just if they find out if we don't have something for them. So then we try and get them some help psychiatric-wise. So, and if we do, we're sending to detox, we do a medical clearance the same way. So especially our alcoholics, that kind of stuff, tend to have admitted more people for hyponatremia that are alcoholics than anything. Probably the lowest sodium I've ever seen, 105, is what I so, and they were just normal, talking, sitting in well, we have these little chair beds for people that aren't really sick, and they're about like, I'm fine, you know, we need to get you to the ICU from the chair bed. So, anyway, so withdrawal, so like I said, some are dangerous, some just suck. So, common symptoms, you know, nausea, vomiting, headache, myalgias, tremors, shakes, with you get some hallucinations sometimes, you know, big time agitation. So opioids, meth, THC, cocaine, you know, you would think that some of those things are like, oh my gosh, you're coming out on those things, you can really have some bad things. Really, just dehydration, rhabdo, those kinds of things are common. And they just kind of feel bad, especially opioids, and people just feel cruddy. The biggest thing is that they don't eat or drink because they're nauseous or vomiting, have diarrhea, they can dehydrate. So, benzos and alcohol are probably the worst ones to kind of quit all of a sudden. So if anybody's thinking about quitting, you might want to kind of tailor it off a little bit. All right. Because big time seizure risk, especially if you've already had a previous history of seizures. Okay. And so, especially with benzos, alcohol as well, and then with alcohol you get the DTs and that kind of stuff, which we'll talk about in a second. So, treatment fluids, antiemetics, benzos, these kind of things. So for DTs, so it's between 24 and 72 hours after the last drink. And so most people's last drink is a doozy. Especially if they're coming in for treatment. And it's, you know, people will say, oh, I just stopped drinking, last night around 2 in the morning, I had my last drink. And it's say 10 in the morning now, and their alcohol's still 400 and something. You know, like, yeah, oh my gosh, you're a professional, okay. And so, you know, coming down from that level is a little bit subjective because, you know, you usually have to be down to you know, some people's. Sometimes I just start over. We say sometimes we get some people where will have an alcohol level and like, well, they can't be going through withdrawal. They're still intoxicated. Yeah, but they normally live at 430, and now they're down to 150, and so that's like zero for most people. So you kind of have to go through that a little bit. So evaluate what the patient, they're a daily drinker, feel different than a binge drinker versus somebody who's just got out of control recently versus somebody who's chronic, you know, pint of Kentucky Deluxe daily kind of thing. So. All right, so there you get the tremor, the shakes are kind of the first thing, confused, hallucinations. It's not as common, I don't know, people just don't want to tell us about their hallucinations sometimes, but I like to ask about hallucinations. So I've read a lot of Oliver Sacks books, so, so the man who thought his wife was a hat, hallucinations, he's got the, blanking on the name. That's frustrating. So, anyway, the one with Robin Williams and all that kind of stuff. Anyway, not Patch Adams. I'll think of it. But anyway, so I'm kind of interested in that stuff, so I'm kind of a nerd about those kind of things. So you have dehydrated, seizures, of course, okay? And so what we want to do is try and keep this from happening, obviously. So getting them on some fluids. Now, I caution you on just randomly starting fluids on alcoholics, especially older people, without first getting some information about their electrolytes because of that hyponatremia, so that start giving a whole bunch of fluid, saline, that kind of stuff to somebody who's hyponatremic. We can actually cause some pretty bad damage in the brain. So, okay. So we want to manage those symptoms with, benzos, so Ativan, Librium, those kinds of things. We want to give some thiamine, okay, so it's a vitamin, multivitamins, folic acid, those kinds of things. Okay. And then there's a score here up on here, so I don't actually use this, but it's been shown to kind of help reduce the amount of people having seizures from it. So basically you start off with a score, they're having hallucinations, they're having, I got a whole thing on my phone if I feel like everybody need to use it, but you kind of put it in there, they, seeing things, are they acting agitated, is their heart rate up, and you give them this much medicine every hour, and it kind of helps you kind of go through these things and helps them. It's more for the long-term facility a little bit. So. Questions on DTs?
Was it Awakenings?
Yes, good job. You get a gold star. All right, so the goal to make sure is everybody medically stable, like we talked about, okay? Make sure they're not endanger themselves, others, especially me, okay? And then get them to some kind of appropriate care. Outpatient, so we try and get them resources. Some people even try and get them an appointment. So our counselors in the ER actually call psychiatric offices and say, hey, I got this patient here, I really think they need to get in. Can you see him tomorrow? And oftentimes they'll say yes. And so now they may have think that they're going to get medicines that time. Sometimes in some places they don't do that. They get them in for like an initial kind of visit, and then they see the psychiatrist, the next time or something like that. But at least they're kind of in the process of going. We're trying to let them know that stuff. So, most of our patients don't stay at our facility. They actually go to a crisis center. So here in Oklahoma City, people go to the Oklahoma County Crisis and Intervention Center, which is kind of over by the fairgrounds. And it has their own, they have their own inpatient stuff there. They also will transfer to the other state facilities, so Griffin and Norman and Red Rock. We've got some places like in Fort Supply and different places throughout the state. And so average time they're there at a psychiatric facility about 2 to 3 days, so it's not very long. So they're basically there to get stabilized and then hopefully follow up outpatient. So the frustrating thing I noticed whenever I was doing my psych rotation with Griffin was that the patients would come in, they'd be kind of disheveled, crazy, we'd feel a little bit better when they left, but we'd transfer them back to where do you want to go? And the social worker would be like, I don't have a home. All right, we'll send you to the Jesus house. So to the Jesus house, so back in the same situation, not do drugs, not take their medicines, vicious cycle. So it's very cyclical, unfortunately, because we don't, keep people locked up or institutionalized. So.
What level would you tell them would be safe before transport if you're having them sent to a facility after you brought their alcohol level down?
So it depends. The facilities usually have a level that they want.
So it's facility dependent.
Yeah. So like our facility is 200. Most other places are about 150. So that's again kind of subjective. So some people 150 is going to be pretty awful. Other people it's they're still pretty intoxicated. So that's sometimes fortunately these levels are hard and fast for the facilities. kind of help manage the symptoms a little bit, even if they're still technically intoxicated, so. So, no abuse of the system, so, it's not one of those cuckoo's nest, nobody's getting, electroshock therapy in these places, they're, not just wandering the walls for, years on end, that kind of stuff. There's probably a few people who benefit from, just being in one place for a long period of time, but, we deem as a society that that's not what's gonna happen now, so. You got a lot of homeless people, kind of, who are kind of abusing the system a little bit, but just maybe because of lack of some effort on their part and access and different things, so, and I'm sure you're probably already aware of this, the funding crisis is upcoming, we're not looking forward to that in the ER, so we're actually starting to kind of make some plans for kind of some longer term stay people in the emergency room that we're going to be looking for placement. Talk about trying to bring a psychiatrist down to the emergency room to try and clear some people who are kind of, wishy-washy. And so, and to be definitely doing some reevaluations on some people, which is, provides a little bit more, keeps us a little more legally sound, hopefully. So, anyway, so you gotta kind of make this determination. If somebody's, are they lying? Are they full of it? Are you willing to bet your license on it? Your nurse's license, your counselor's license, whoever you're working with. You willing to bet the facility's not going to get sued for this? You don't want your patient to be found in the Oklahoma River with a St. Anthony's wristband on. Not my patient, but one of our patients. So it's never good. So anyway, you got to document if you are sending somebody home. You document what steps you're taking, why you think that this person is not really suicidal. Oftentimes these people, when they're just talking, will kind of admit that they have some future-oriented goals already. Well, I'm really trying to get into this new apartment, and it's not going to be for so long, so I'm suicidal. Like, oh, so you're looking forward to getting into this new apartment? That's great, excellent. You're future-oriented. So, anyway, so the ped psych patient, these crazy little guys. So, it's about 3% of the child and adolescent ER visits. It's actually quite a lot. Everything else is a snotty nose, right? So they come from unstable families, abusive families. They're in foster care. They've been in 5 different foster homes. They've got court-ordered things on them, kind of stuff. We had a patient recently who had a letter from a judge that said that they could have no physical or verbal reprimand. How are you supposed to teach a child this with this? I don't know. So basically, the only thing they could do is put them in holds if they're agitated, and give them medicine. So that's not a winning success right there. So unfortunately, that's what we're dealt with in life sometimes. So. You got to kind of manage these things. I mean, sometimes you talk to a family member, mother, aunt, whoever's taking care of this person. You're talking to them, and you're like, "Oh, I'm ready to admit the mom for something." The kid is like perfectly fine. They're sitting there, playing a game on a phone, and like, "Can we put her in the hospital?" And so there's definitely some family dynamics that we take into account here. So, and a lot of times they get sent to us, like, again, just because they want to get cleared for, go back to school or get some resources or something like that. So the, school system, of course, doesn't want to be shown to have not done anything with this person who made a suicidal statement, and then, 3 weeks later they're dead or something like that. That'd be awful. And so they send us do some acuity screening to see if there's an acute situation or not. So, okay. So. And then most drugs are understudied in the peds population, so so that's why I try and stick with the few that work. But you get some kids that are on some massive doses of adult psychiatric medicines. Like, Jesus, this would knock down a horse, and this little 8-year-old is bouncing around the room with all this trazodone on it, or Seroquel and different things, or Spiridol. Some of these kids they're drug cocktails that you look at, and like, if just Lansing, they're drug list, you're like, hey, is this like a 60-year-old lady? Or is this like a, you know, an 8-year-old girl? I mean, goodness. So, and a lot of them are on ADHD medicines and those kinds of things, so. And, you know, the kid's gonna grow out of their medicines too, so if they started on something, and then, you know, they hit growth spurt, and those kind of things, hormones and stuff, so sometimes your medicines don't work as well anymore, so you need reevaluation. And sometimes if that doesn't happen in a timely manner, then they can, you know, get pretty agitated and actually have a need for admission. So, we're pretty strict on what we admit for PED stuff, because there's so many lack of beds, and so unfortunately, if we get some kids that have a lot of mental illness or have a low IQ or something like that, they're really hard to place. There's only a couple facilities that are been deemed that can kind of take care of these people, and so they require special attention. I guess our facility just hasn't kept up with that. So, and if you're concerned, you always call DHS. Call Ferry E. Nichols, real person. Love it. Questions on psych?
How many psych facilities in the Oklahoma City metro area accept PEDS?
So Saints does, Midwest City does. There's some place called Cedar Ridge does, and one of the Integris facilities at Spencer, out in Spencer does. So that's pretty much it. And OU does some things, but not a whole lot of, it's usually like their psych stuff's related to people who are already kind of admitted medically and they're having some psychiatric problems. So usually there's got to be a reason for them to be there otherwise. Good question. And then there's places in Norman and some other places too. But, yeah, so yeah, there's still not a lot. So there's often times when we're telling the parents, well, the only place that's, you know, you can wait here for another 30 hours, or you can go to Tulsa, take care of you to Tulsa. And so sometimes that's the best option for them. Ada or someplace that's pretty far away. Okay. Other questions on site? Ready for break?